Okay, hello class, welcome to the online session. We are going to discuss on 6 slides for this activity. We have slide 51, that is nodular lymphocytic lymphoma, and this is also called follicular lymphoma. Next we have slide 54, large cell lymphoma, slide 114, gastric lymphoma, slide 191, Hodgkin's lymphoma, that is nodular sclerosing, slide 12, Gaucher's disease, and slide 61, that is chronic passive congestion of the spleen. Okay, so let's start with follicular lymphoma, which is slide 51. Follicular lymphoma would fall under the non-Hodgkin's lymphoma. Okay, so when we are talking about lymphoma, it would be divided into the non-Hodgkin's and the Hodgkin's lymphoma. So when you are talking about non-Hodgkin's lymphoma, usually in a tumor, all of the lymphoid cells present, or in almost all cases, they are all involved. So it means that they are all neoplastic. When we are talking about Hodgkin's lymphoma, it means that there is only a subset of cells, that is less than 10% of the population, that would be neoplastic, and they are called the Reed-Sternberg cells. The rest of the cell population would be reactive: lymphocytes, histiocytes, eosinophils, neutrophils, plasma cells. Okay, so now with regards to lymphomas, when we diagnose lymphomas, we give the pattern, okay, the pattern, architectural pattern, and the cell type. So non-Hodgkin's lymphoma, diffuse or follicular, small cell, large cell, or mixed small and large cell type. So that is how we give a diagnosis for non-Hodgkin's lymphoma. So in this case, this is a follicular lymphoma. So when we are going to diagnose this one, we are going to place there non-Hodgkin's lymphoma, follicular type, and then small cell type. Okay, so how do we diagnose this one? It's very important because we already have slides that would show follicular pattern. Okay, what are they? The follicular hyperplasia, and we have the reactive hyperplasia of the tonsil. So how do we differentiate follicular lymphoma from the other two? Okay, so first of all, follicular lymphoma would arise from the germinal centers. We have two cell types present, right? We have the centrocytes and the centroblasts. So centrocytes would be the small cells, centroblasts would be the larger cells. And remember, in follicular lymphoma, we do not have, or it's uncommon to have, extranodal involvement. When you say extranodal, it means that we can see presence of lymphomas in non-lymphoid tissues, like liver, like the lungs, and so on and so forth, or the intestine. So follicular lymphoma, they are identified with translocation of the Bcell2 from chromosome 14 to 18. So we have a 14-18 translocation of Bcl2, and this will cause overexpression of Bcl2 in this tumor, okay, in 90% of cases. Also, it's associated with MLL2 mutation in 90% of cases, and this will lead to epigenetic abnormalities with regards to the release of histone methyltransferase. So now we go to how to differentiate follicular lymphoma from hyperplasia, and from reactive hyperplasia and follicular hyperplasia. So these are the follicles, okay, so they can be vari-sized, but you have to look into the individual follicles. Okay, so what would be prominent would be a monoclonal population. Okay, so it means that the cells present here within the germinal center would be similar to the cells that we would see on the outermost region, the mantle zone. Okay, so they are all the same. You do not see the light and dark zones that we saw in the reactive hyperplasia of the tonsil. Okay, so those are the most important differentiating features. So number one, absence of the light and dark zones, and then the mantle zone would not be prominent. Okay, so if you're going to look at the other follicles, mantle zone is not present or not prominent. Okay, here, and then light and dark zones are not visible. And aside from that, we're going to do immunohistochemical stains for these cells. You would see that there would be an overexpression of Bcl2 within the follicle. Okay, within the follicle, within the germinal center. So immunohistochemical stain would show uh, uh, presence of reactivity. There would be brown color, brown staining in this case. In follicular hyperplasia and reactive hyperplasia, this will not light up. So there's no Bcl2 overexpression in follicular hyperplasia and reactive hyperplasia. Only in follicular lymphoma. So again, this would show Bcl2 overexpression. With regards to the markers, because this is a B-cell tumor, it would be positive for CD19, 20, 10, surface immunoglobulin, and we also have Bcl6 overexpression. Now we go to slide 54. This is the diffuse large B-cell type, okay, of lymphoma. Okay, so diffuse large B-cell type, it can be nodal or extranodal. Let's go into the tissue because it can be nodal or extranodal, so you have to move around whether this is nodal or extranodal. Okay. Okay. So what you see here would be the presence of glands. Okay. So presence of glands, this would be colonic tissues. So this is an extranodal lymphoma. And then we look into the cells. Okay, they are monotonous. So most probably this is a non-Hodgkin's lymphoma. And then diffuse. It's a diffuse pattern. We do not see germinal centers or follicular patterns. So this is a diffuse type. And then we look into the high power magnification. Okay, they are larger than usual. So we call it as a diffuse large cell type of non-Hodgkin's lymphoma. So these cells would show enlargement of the nucleus. Okay, they can have vesicular nuclei. They can have prominence of the nucleolus. They can have multinucleation. Here, this one you have prominence of the nucleolus, irregularity in the nuclear membrane, prominence of the nucleolus. In this case, okay. 30% of these cases would show Bcl6 overexpression. 10 to 20% would show Bcl2 overexpression. And 5% would show MYC overexpression. So again, this would be a non-Hodgkin's lymphoma, diffuse, and large cell type. Okay. Next we have slide 114. This is gastric lymphoma. Okay. So there's a need to look into whether it's nodal or extranodal. Okay. So is it extranodal or nodal? Okay. So in this case, we would see the presence of epithelial. Uh, so uh, we have an epithelial lining here, which is gastric. Okay. So this is gastric. There's the presence of the parietal cells. Okay. And where do we see the tumor cells? It's located at the submucosal portion. Is it diffuse or follicular? Okay, so it's diffuse. And then we look into the cells. Are they small, large cell? Okay. So they are large cells. Okay. So in this particular slide, very important to identify the gastric lining. Okay. So the cells here are derived from the lymphoid tissues of the gastric tissue. We call them as maltomas or mucosa-associated lymphoid tumors or maltomas. And they are known to have extranodal sites that is located at the mucosal areas, like in the intestine, like in the salivary area. Okay, so they can arise from autoimmune disorders or infectious disorders. And like in the gastric lymphomas, because it's associated with an infectious agent like H. pylori or Helicobacter pylori, it may regress once the H. pylori would be eradicated. However, if there would be the formation of mutations in this particular lymphoma, it will not regress even with eradication of the H. pylori. So this particular cell type would show overexpression of Bcl10 and MALT1. Okay? So this particular tumor would show large cells with vesicular nucleus, prominence of the nucleolus. Okay? Very similar to the diffuse large B-cell lymphoma. However, in this case, this would show very vesicular nucleus. Okay? Not much chromatin pattern. And then always check on the lining epithelium. Okay? Next, we have Hodgkin's lymphoma. So, Hodgkin's lymphoma is different from the non-Hodgkin's lymphoma in a sense that we should be able to identify the Reed-Sternberg cells to be the only neoplastic cells present in the tumor. Okay, the rest of the cells should be reactive. Okay, so before we start with the discussion on this particular variant, it's important that we discuss on the 5 variants of Hodgkin's lymphoma. So first we have the non-nodular sclerosing, then we have the mixed cellularity, we have the lymphocyte-rich, lymphocyte depletion, and lymphocyte predominance. So in the book, you have the tabulation, and you just have to remember those things because those are the differentiating features for each of the variant. The nodular sclerosis is it's the most common variant. And mixed cellularity, you have the presence of a mixed population, no sclerosing, no collagen bands. What about the lymphocyte-rich, lymphocyte depletion, and lymphocyte predominance? They all have the lymphocyte in their title, in their name. Okay, lymphocyte-rich, it would show the presence of T cells. Okay, so you have Reed-Sternberg cells with a lot of T cells. What about lymphocyte predominance? Don't they have the same name feature? Because lymphocyte rich and lymphocyte predominance, yes, they have a similarity in the name, but the cell type here would be the B cell. Okay, so again, lymphocyte rich T cell population present, lymphocyte predominance B cell population would be present surrounding the Reed-Sternberg. Okay, so now we go to the differentiating features between non-Hodgkins and Hodgkins. So in Hodgkins, it can be localized to a single axial group. So it means that it can be identified on the left, on the upper portion, lower portion, or right or the left. And then there's orderly spreading of contiguous sites. Extranodal presentation is rare. Okay, so Reed-Sternberg cell. So first we have the variant here would be the nodular sclerosing. So it means that you have to see the presence of large tracts of collagen bands. So you see large tracts of collagen bands surrounding nodular formations of the cells. Okay, nodular formations of the cells. Next, we go to tracking or locating for the Reed-Sternberg cells. So in this particular magnification, you would already identify that there are large cells. Now we go into the high power magnification. Okay, so you look at the population. Okay, do all look neoplastic? So there are some cells that are small, okay, and there are some cells that are large. So it's not monotonous. So this is most probably a Hodgkin's lymphoma. So the cells that we have here, the large cells, can be can present with multinucleation like this one, or would present with a single nucleus with multilobation like this one. Okay, with prominence of the nucleoli. So we have variants for the Reed-Sternberg cells. Let's try to look for a lacunar cell. Okay, this one. So it is a lacunar cell. So a lacunar cell would be, these are Reed-Sternberg cells that would show the typical appearance, okay, having multinucleation, and it is found within an empty space like this one, so like a lacuna. So that's why they are called lacunar cells. Okay, so here you would see typical Reed-Sternberg cell, okay, with two nuclei, prominence of the nucleolus or nucleoli. Okay, so those are Reed-Sternberg cells. They are positive for CD15 and CD30 and PAX5. Okay, so CD15, CD30, PAX5, and they are negative for T cell and B cell markers. Okay. Okay, so next we go to slide 12. We are now through with the lymphomas. We go first with slide 12, which is Gaucher's disease. So Gaucher's disease would affect not only the spleen, because this is the spleen, it can also affect the lung, the bone marrow, lymph nodes, tonsils, the thymus, and the Peyer's patches. Okay, so what's a Gaucher's disease? This is a lysosomal storage disease. It's autosomal recessive. This is due to a mutation to the gene that encodes for the glucocerebrosidase, causing glucocerebroside accumulation. The glucocerebroside would then be taken up or phagocytosed by macrophages, and that's what we are going to look for. Okay. So this is the spleen. In the spleen, we have two regions, the white pulp and the red pulp. So this would be the white pulp with the central artery. Okay, remember that one. Okay, and then the outer areas here would be the red pulp, which would show the sinuses. So what should we be looking for? We should look for the macrophages or phagocytes. Normally in the spleen, we do not see a lot of large cells. Okay, but in this case, you see aggregates of the cells, which we would call as the Gaucher cells. So these cells would have, so these are macrophages with abundant cytoplasm. In the book, it would say that it has a toilet paper configuration because of the fibrillary pattern of the cytoplasm. Okay. And then we have slide 61. This is called chronic passive congestion of the spleen. This is identified with liver cirrhosis, which is the most common cause. This is also identified with cardiac decompensation with right-sided heart failure. So again, you have the presence of the red and white pulp. This would be the white pulp with the central artery. Okay, so white pulp with the central arteries, and then the rest would be the red pulp. So notice that there would be the diminution in the size of the white pulp and then expanded red pulp areas. So you have red cells and fibrin. This is congestion. Okay, so those are the slides that we have for today's session. So kindly study them, stay safe, and good night.